providers should know to meet the needs for transgender men? I don't write these questions, but did you understand that?
Yeah,
okay.
I understand it. So most people know me as Mr. Chris in the community, and actually through the U.S. because I travel a lot to different conferences all over the U.S. And funny enough, when we started our clinic, the administration was responsible for the doctors and nurses. They're like, okay, transgender program, yay. But then when we had patients coming in, the nurses were like, well, we're having a transgender program. Why are all these men coming? And it's because 90 to 95% of the population that we happen to serve ends up being transgender men, female to male trans individuals, which is usually the opposite when you think of transgender care. Most people think of trans women or male to female. So a lot of times, our patients come in and for the first 3 months, people kind of thought they were lost. So as this sort of came about, we started to get more calls and contacts about, serving transgender men. And as I travel and tell people, when they ask, like, what does our population look like? And I tell them the numbers of, like, right now we only have, I actually, sat and counted, but in terms of active patients that are trans women, 12. That's how many are trans women. And that speaks to the needs. And a lot of the trans women we get, when we do the intake or when I, talk to them before they're coming in, one of the things that we ask them about why they're switching care if they've already been in care, and they say it's because their provider might have had 20 years of experience with trans patients, but they're not sensitive to the needs of trans men. And some of the issues, that come up is, if someone is early in their transition or sometimes look gender ambiguous and they happen to disclose that they're transgender, then people start calling them female pronouns, thinking that they're acknowledging their identity when in fact they're actually getting it wrong. So knowing that, transgender men exist, I think is the beginning for providers. And then from that, knowing different things about sexual identity, because I heard comments and saw the reactions when Nathan was speaking, and he's transgender, oh my gosh, but then he has sex with men too? Is that really what he said? And I heard these comments behind me, and I've heard Nathan speak before, for years, and I'm always in the audience, and I always hear these reactions, so the assumption that trans men only have sex with women is still perpetuated. So when, there's safer sex stuff, like someone said, oh, well, you work with trans men, so I'm going to give you a bunch of dental dams. And I'm like, well, you might as well send some Magnum, some finger cocks, some flavored condoms. And they're like, well, why do they need that if they're having sex with women? And I said, well, you're assuming who they're having sex with and what kind of sex they're having. Mm-hmm. And when we have tables of different safer sex materials, most of our clients pick up condoms, not dental dams. So the assumption that they need dental dams is really outplaced, so knowing that. Also, dealing with insurance, annual care. Earlier, one of the doctors spoke about Code 45 when it comes to Medicaid and Medicare. I'm glad someone outside of me in New York City has actually said this, because I've been saying it for years, and people look at me like I have 10 heads. So if someone needs like a gender-specific procedure, people are quick to say, oh, Medicaid's not going to cover that, Medicare's not going to cover that. But if a patient needs something, a patient needs something, regardless of what their gender is and whether they're of trans experience. Providers should also know not to make assumptions about people's bodies. I had a patient come in and, well, not to us, but they told me that they went to another provider, and the provider started talking to them about having a pap smear, and they said, well, I don't need one. They said, oh, but you have a vagina and you should still get it checked. And they said, no, I don't need one because I no longer have a vagina. I had, genital reconstructive surgery. And then the provider was like, oh, well, what does that look like? Or, oh, well, it's not going to have any feeling. I hear that those don't work. And in fact, the patient has sexual sensations, very sexually satisfied, and their genitals do work. But a lot of providers have their own misconceptions, or they think like it's not going to look real. And I've had patients who have gone to the emergency room, gotten fully naked, and have not had to disclose their transition history. So going back to what Nathan said about people lying, that's very common. So sometimes asking people, what sort of surgeries they had or what they were assigned at birth can be important. Will people lie? Yes. I know people who tell me they lie all the time. Like if someone is going in for a broken arm, they're not necessarily going to tell the provider that they're transgender if they might have quote-unquote passing privilege and the person doesn't assume they're transgender, then they won't say anything, because then they'll spend more time getting questions about, their genitals than the fact that their arm is broken. So providers need to remember that. And wherever you are on the provider spectrum, whether you're a case manager, community follow-up worker, primary care physician, HIV counselor and tester, nurse practitioner, or any of those things, or anything I didn't list, you're still considered a provider. You should still consider professionalism. Going up to the next person and saying, "Ooh, that one? They look good, right? That was really that was born a." How is that relevant to other people? And also, how is it your place to tell that person's story? And I've seen many a times people's safety jeopardized because when caseworker A is telling caseworker B, they don't realize that random client number 3 is sitting in the waiting room, overhears them, and then calls out that young trans man or trans woman in the street and then gets them beat up by telling other people. So we have to be mindful to respect people's privacy, especially when it comes to trans men, because there seems to be this astonishment about how well some trans men can pass after years on hormone replacement therapy, that people feel the need to tell everyone they see that that person was assigned female at birth. Also, not imposing personal beliefs. Sometimes when trans men are talking about having hysterectomies, I've heard many conversations about doctors telling, trans men, "Oh, but you'll miss out on the wonderful joy of giving birth."
Oh, wow.
Try to give birth to 10 people.
And I know many cisgender women who will not describe labor as the wonderful joy.
No.
So telling this to trans men can be very traumatic and offensive. So keeping that in mind. Also, having updated versions of the standards of care. I saw 2 presentations today that had like version 5 and or version 6 of the standards of care, and between version 6 and version 7, which came out version 7 of the standards of care can be found on WPATH.org, WPATH.org, the World Professional Association for Transgender Health, which was formerly known as the Harry Benjamin Society. That updated standard eliminates a lot of gatekeeping shenanigans and things like that. I have seen therapists make patients pay $200 a pop for therapy sessions, mandate them to come to 10 sessions, so 200 times 10, that gives you 2,000, and then on session number 10, the therapist says, "Oh, I'm not going to give you a letter because I don't believe in that transgender stuff." So they're abusing, so they used to abuse the fact that the old standards required a certain amount of mental health, and then would take thousands of dollars from transgender patients or swipe that insurance card a bunch of times and then never care for the patient. So the new standard sort of eliminates a lot of that and also makes transition paths more individualized. Not every person is going to want every surgery out there. Some people may not want any surgery. Some people may be on hormones from the age of 16. Some people may be 60 and never opt to use a hormone a day in their life, but that doesn't make them any less transgender. they might have different needs depending on what medical interventions they choose to seek or not seek. But as providers, you should remember that all patients are individuals. And another thing to say for providers, and this will be my last point, please do not prescribe all patients the same hormonal regimen. I have met providers all over the U.S., and for trans men, they start everyone at 0.5 cc every week, or 1 cc every 2 weeks. If you had a diabetic patient, a patient with high blood pressure, a patient with high cholesterol, you wouldn't prescribe everyone 12.5 milligrams of hydrochlorothiazide. You would go based off of what their medical history is, what their labs say, what their baseline is, and go from there. So I have seen a lot of providers who think that, well, at least I'm prescribing it, is doing service to their patients, and it's not. And there's a lot of people prescribing Pregarin and spironolactone and injections and a patch and too much stuff at the same time. I think the providers we have here, because they're more knowledgeable, had better options of regimens, but I do see some knowledgeable providers sometimes making those mistakes of doing a one-size-fits-all, and then their patients having problems. So remembering that even though someone might be labeled as transgender or a trans man, not everyone is going to look the same or need the same medical care, and to remember that you're dealing with an individual.
Thank you.